adjuvant treatment. But as soon as we come to nodal disease and a little bit more extensive local disease, I think nowadays we always have to add some adjuvant treatment, which is radiation in lower stage and chemoradiation in higher stage in the post-op situation. And for the locally advanced cases, always some kind of multimodality treatment where you use chemoradiation targeted therapies or additive selective neck dissection for some kind of residual disease. But in the very early cases, for instance, I think surgery is still the mainstay. You need not to add anything. And we are currently trying to establish a German study of the ARO, where we in T1, T2, and N0 and 1 oropharyngeal cancer cases and oral cavity cancer cases will just compare pure surgery versus surgery plus some adjuvant irradiation.
Okay, Arlene, yeah.
Oh, well, I would agree that for T1s, most T2s, N0, N1 clinically staged disease, that either radiation alone or surgery alone, depending on the site and the institutional expertise, et cetera, would be adequate therapy if the patient's upstaged based on surgical pathology, for instance, with more neck disease, extracapsular extension that was unexpected. Then certainly there would be indications then to consider chemotherapy in the adjuvant setting with radiation. But otherwise, I would agree that a single modality would be the appropriate management.
René?
Yeah, totally agree. It's funny that Volker doesn't mention radiation therapy, but we do a lot of primary radiation for early stage cancers.
We don't do it at all.
Okay, so here we have a surgeon promoting radiation and a radiation oncologist promoting surgery. So that's in the spirit of multidisciplinary care. Jeff, yeah.
Well, probably more like René in the practice of our institution is to treat a number of oral, non-oral cavity sites, early tumors with radiation alone where possible. I think one of the advantages in oral cavity cancer, where we tend to treat these surgically, is we tend to stage the neck with elective neck dissection for those that are clinically node negative. And our biomarker there is either node positive or ECS positive disease that helps us select our adjuvant treatment. And whether a conglomerate of biomarkers will be as effective as just pathologic nodal status or the presence of ECS or not, that we could just look at in the primary tumor and select the adjuvant modalities and not need to treat the neck, remains to be seen. And speaking to Stefan Tamam, they're ahead of us in terms of using sentinel node biopsy to select patients for further treatment of the neck. And I think that's something we need to learn about more and explore more, because that's a way of reducing some of the morbidity of surgery.
Yeah, and I think we need to realize that the technique of surgery has improved. Robotic surgery is coming. The technique of radiation has improved. IMRT, in selected cases now, we can even just treat the tumor ipsilaterally so that we can spare function quite a bit. Now, just to remain in the early stage, does new imaging modality really affect your practice, such as PET scan or functional imaging? You think it is here to help us, or do we still need to wait and test this in a proper fashion? Maybe starting with Jeff now.
Well, I think probably the full potential of it has yet to be realized because we haven't maybe incorporated and tested it as much. But I think it has utility. occasionally if someone's never been biopsied with an unknown primary, we pick up primary. It's not very common, but sometimes we do, and that can be a benefit. Sometimes we don't always order PET scans, but people bring them, and sometimes nodal mets are picked up and they're upstaged. So I think there is some utility, but I'm not certain. It's not always a test that I order on every patient because I'm not always certain that it's going to change what I do above what I learned from a CAT scan or MRI.
Great. Renee?
Yeah, likewise, we don't do that many PET scans for early stage lesions, T1, T2s. Of course, we do MRIs for oropharyngeal cancer.